undoubtedly, psychiatrists have changed their mind over the last 20 years. I used to get invited to debates to debate, does cannabis cause psychosis? Yes or no, and I would debate with some other person, and I nearly always lost because psychiatrists didn't think cannabis caused psychosis. I never get invited to such debates any longer because it's not a question. It's widely accepted that cannabis can cause psychosis, but it's not widely known how big a deal this is. And we know from studies that Marta has played a big role in that psychosis is 5 or more times commoner in South London than it is in southern Spain or southern Italy. And one of the big factors in this is that we use much more cannabis and much more potent cannabis in South London than they do in these areas.
You have found the Thinking Mind podcast.
Thank you so much for joining us today on the podcast. And in fact, Professor Murray, it's a pleasure to have you back a second time. And for anyone who is interested in learning a little bit more about psychosis, please do tune into episode 12, which is where Professor Murray spoke to Alex previously. Today, however, I'd like to take us on a slightly different track, and I hope to take us on a little bit of a whirlwind tour around cannabis. So I hope to speak to you and find out more from you both about the fantastic research that you've done on cannabis, particularly looking at some of the big international studies that you've done. I believe that we might have some exciting new data that we might be able to discuss with you today. But also, I'd really like to talk about the clinical work that you do, both with patients with psychosis, but also in the cannabis clinic that you run and the cannabis peer group that you run, Dr. Di Forti. So, without further ado, to kick us off, could I ask you both to share with us a little bit about what a typical week in your work might look like?
A typical week, of course, is a COVID week. And so I am pretty well hiding at our home in Wimbledon, doing all my work virtually. And so that is doing research, doing teaching, and going to conferences or giving lectures. Because one of the unexpected side effects is that people all over the world have discovered that you can invite speakers come and give a lecture at no cost. It used to be that they would have to fly you to New York or Singapore, but now they know that you can give a lecture free.
The catchment area where I work as a consultant psychiatrist, which is Lambert, has been very busy, not only on the first wave of COVID with COVID cases, but also more recently with a significant increase of new referral of young adults with first episode psychosis. So my clinical work has increased, and the cannabis clinic that I know we'll be talking about a little bit has expanded. So this brings me often down to Lambert, to Kennington Lane, which is where the team base for the Leo team lives. But also I've been working as a volunteer vaccinator for our trust for SLAM. And the rest of the time, like Robin, I'll be doing my academic work online, which includes teaching, student supervision, the running of the cannabis clinic, which has been remote since the start of the pandemic, and less conferences, but some conferences as well. But we're very privileged because we live next to Wimbledon Common. So beginning and end of the day is about walking our Labrador for an hour and a half or so. So that keeps the mental health well and steady.
So I wonder if I could take us perhaps a little initially in the direction of your research. And I wonder if you could talk to me about what problem or what question your research is trying to solve at the moment or recently.
So I certainly started getting interested in cannabis and psychosis maybe 20 years ago. And that was after ignoring relatives and what they were saying, sadly, for several years, because patients' fathers or mothers often would say, he smokes an awful lot of cannabis. Could that have anything to do with the fact he's got ill? And I would say, no, I think all the evidence is that cannabis is a safe drug. It must just be a coincidence. But after I heard this so many times, I began to think maybe there's something in it. So we started looking at the question of, first of all, we started to see whether people who were already psychotic, if they continued their cannabis use, patients often say that they take the cannabis as a sort of self-medication. And if that were true, you would expect them to do better than the people who don't take cannabis. But in fact, they do much worse. So if somebody is psychotic and they are taking cannabis, they will do badly. If they stop using cannabis, they may do quite well. So after showing that, we then got started on, does the cannabis actually contribute to the origins of the illness? And to do that, you have to do a prospective study. It's like, how did they show that cigarettes caused lung cancer? Take a big sample of people out in the community, see who smokes cigarettes, and then follow them up for a long, long time. And you find that those who smoke cigarettes have a much higher frequency of lung cancer. And it's the same with cannabis. So you follow up young people, the ones who are smoking cannabis, particularly heavy cannabis, high potency cannabis, have a much higher risk of developing psychosis. 20 years ago, if I raised the question, does cannabis cause psychosis, people would mutter about reefer madness and this is ridiculous. I remember appearing on Channel 4 News and having Jon Snow laugh at me because of this suggestion. Well, as the comedians say, they're not laughing now. Over to you.
So it's quite interesting what Robin said, especially when he mentioned high potency, because when I did my training in psychiatry at St. George's, so in the St. George's rotation, but then I moved to the Maudsley to do my higher training, and I wanted to do research. So I was doing my higher training, but I started also a PhD. And when I worked in St. George's, my catchment area would include Sutton, Surrey or Tooting, where there was very little cannabis among the patients presenting with psychosis. There was actually less psychosis than the one I came across when I moved to the Maudsley. And so I became very interested in the question of cannabis and psychosis, also because the literature that Robin mentioned was beginning to building up from the longitudinal studies. But still, something that was quite relevant to my clinical work, and mostly coming from the conversation with my patients, especially the one with psychosis, was, well, if it is true that cannabis has contributed to my psychosis, why my friends who are using as well are not actually coming to the attention of mental health services? And so I really thought to develop a PhD that could start addressing the question, who are the cannabis users at risk of developing psychosis? And the first thing that struck me is that most of the literature, even prestigious publication who had an impact at the time on the reclassification of cannabis, for instance, had based all their analysis primarily on the question, have you used cannabis, yes or no? And there were very few studies who had some measure of quantity, but they were really, if you ask me, a bit pathetic, like the landmark study from the Swedish court had a measure of quantity where the greatest consumption was estimated as more than 50 times in your lifetime. My patients use 50 times in a week. So I thought, well, perhaps a very simple way to start would be to ask the cannabis history better. And this was not something that we invented. It's something that if you look at anything else in addiction, alcohol, tobacco, when you take an alcohol history, you really ask about daily consumption, you get into units, you ask when people started, how long, the type of alcohol they consume. And so we used a questionnaire, who at the time was already validated, which is the Cannabis Experience Questionnaire, and we added some question on type of cannabis used, because there was, again, we're talking about mid-late 2000, there was a talk about the type of cannabis changing in society, becoming more concentrated. And so thanks to the collection of these data, and as part of my PhD, we were able to examine if the type of cannabis that people used, and in particular, if the amount of THC, which is delta-9 tetrahydrocannabinol, which is the active ingredient of cannabis responsible for the recreational effect, but also for the harmful effect in terms of mental health, would make a difference to the probability of suffering from a psychotic disorder. And what we found indeed was that the one that use skunk-like cannabis, which is the type of cannabis you mostly find in South London, and the one that we consider high potency, because it has a THC on average of around 14%, were 5 times more likely to develop a psychotic disorder, especially when they use daily, compared to people who had never used cannabis. And that was different because the previous studies, even the longitudinal one, that had looked at the famous question, have you used cannabis, yes or no, found that the effect on risk of developing psychosis was of doubling it. So there was a sort of twofold increase in the risk. When by asking simpler questions like what type of cannabis you use and having an idea on the frequency, we reach a 5-fold increase in the probability. So that was a hint that perhaps having a more detailed information on how much people use and what they're using was getting us close to who are the cannabis users more likely to develop a psychotic disorder.
What you describe in terms of the difficulty in knowing how much people are using, that's a really big issue at the moment, isn't it?
So in some way, it's when you think about the world of addiction. So if we forget for a second psychosis, clinicians who work in addiction know that it's difficult to take a drug history because you have to rely on the individual unless you want to know what they were using on the day when you've seen them. And so you might want to take a blood sample or a urine sample. But if you want to take a long-term history from when they started to the time you see them, even biological measures are pretty useless because they won't confirm that when they tell you that they start at age 15. If you're interviewing at age 20, this is the case. They might give you, especially for cannabis, but even other drugs, if you have somebody with long hair and you take a hair specimen, you might have an estimate of use over time. But again, this depends how many times they've cut their hair in the previous sort of 10 years. And certainly they won't tell you how much THC or other cannabinoids like CBD, cannabidiol, there was in the cannabis they used 4 weeks or 5 weeks or 6 weeks before you've seen them. They only give you a snapshot on the day. So these are all data where you have to rely on self-report. Now, there's always been, if you don't mind me saying that, a quite patronizing view of how people are reliable in terms of reporting their cannabis use. There is always this idea that people who drink alcohol will never be very specific because by the time they had half of their consumption, they're too drunk to recall what they were doing. And there is the idea that people that take cannabis won't tell you exactly how much they're using or what they're using because they don't know. Well, now there have been, at least in cannabis, quite good studies that indicated that people are quite reliable, at least on the type of cannabis they use. This is great work done by Valerie Curran and her team at UCL, where they asked people to bring along a sample of what they were using normally. And then they asked them, what do you think you're using? Do you think, what was the type of cannabis you use? And do you think it's a strong type with lots of THC, or do you think it's a mild type? And they then analyzed the sample. And they also took a blood sample from the individual and tested the amount of THC and CBD. And there was a very high correlation between what people think they're using, what actually is in their blood, and what they found in the sample. Which tells you that, people make choices. And even when they can't make choices because the market now is full only of high potency cannabis, they're actually aware that they are using strong type of cannabis. They might know exactly the percentage of THC because, of course, we rely on the black market, but they would be able to tell you that they are using skunk rather than hash, rather than weed, rather than shatter, rather than amnesia. And we can go on with many street names.
The other thing is that people now that cannabis use is relatively socially acceptable, people don't feel stigmatized by saying that they smoke cannabis. I mean, I think trying to take a history from somebody about taking cocaine or amphetamines or heroin, I think people are going to be much more cautious in telling you the truth. But it's only cannabis, and lots of people don't even think cannabis is a drug, which I guess brings on to another point, that we talk about high potency cannabis as being skunk, which is about 15, on average 15% THC. Occasionally in the UK you might get 20-25% THC, but increasingly around the world we're getting much higher concentrations of THC. So if you go to Holland, you can get nether weed or nether hash, which go up to 40, 50, 60% THC. And we were speaking yesterday to a colleague from Colorado who was saying that the market is not taken over by, I mean, she thinks that skunk is low potency.
Yeah.
That she is concerned about 60, 80, 90, 99% THC. You can get crystal cannabis at 99% THC. So it's a bit like as if the world, the only kind of beer you could drink was shandy or lager. And then, of course, people discovered that you could make wine, which is more potent. And then, of course, they discovered you could distill spirits and get vodka or whiskey. So we're in a bit of a race to get more potent cannabis and also different ways of ingesting it. So most of our patients smoke cannabis together with tobacco, sadly, but some would take it via a bong. And in the US now, people are often eating cannabis. So if you just say, do you smoke cannabis? They'll say, no, I don't smoke cannabis. But they may be consuming it every day in so-called edibles.
Actually, Robin is reminding me of something that happened to me as a clinician, which is relevant to the conversation we were having. So one of the things that the first study on the potency made me realize in my clinician's shoes is how poor was the way I took a cannabis history in my clinical environment. And that wasn't only because I wasn't asking enough questions, but also about the attitude. And I think if you start by saying, do you take any drugs? It's very unlikely you're going to get an answer. If you build that into a context, tell me a little bit about your lifestyle. Is there anything you use or you might take to chill out, to enjoy your friends? You might get more information in that specific context about cannabis. But now this has even changed. So one of my first episode patients was recently admitted in a very unexpected way, was doing extremely well, really extremely well. But then all of a sudden, within a week, becomes very unwell, is admitted to hospital 20 days down the line. And I'd been asking while he was an inpatient, has he reported any substance misuse? And the reason I asked that is because when he was first referred under my care, he had been unwell because of a period of using cannabis. But they were very convinced that he had not touched cannabis at all. They were not able to do a urine test at the time of admission because he was too distressed. So I attended the ward round with the inpatient team last week. And in chatting about what had happened before him being admitted, he came out that he had a cough. And so I asked him, did you take something for your cough? And it turns out that he went online and bought a syrup which contains up to 80% of THC. And his mom was online with us, and she said, well, yes, he bought 3 bottles and he drank 2 bottles of this syrup in 2 days. And then we found the 3rd bottle and she showed it to me because we were doing a video call. So again, the reason why we didn't know...
How was his cough?
Well, I think the cough had become a secondary issue, but he fairly... To be fair, he said that the reason why he drank the 2 bottles in 2 days is because he wasn't getting better with his cough. So there was no advantage in terms of his cough, and certainly there was no advantage in terms of his mental health. But this reminded me that, again, that wasn't picked up because now the use of cannabis has also leaked into the umbrella of medicinal products that are available online rather than from the drug dealer, because he bought it online. And I went and checked online, and you can in fact find this syrup and buy it if you state that you are over 18, and there's not even a way to check that you are actually over 18. So the issue of what people use, how much THC there is in what they use, and how frequently they use it. And as Robin would say, the way they consume it. So in his case, the effect was to do with the concentration of THC, but also the fact that it was an edible. So he didn't get any effect as he would have expected by inhaling it. And so he thought that he needed to use more and more and more to get any effect, despite the high concentration in the syrup. So this is changing the presentation in terms of how fast people develop a psychosis and how severe they present, but also on how difficult it is to actually make the connection, because we need to learn how to ask the questions.
Thinking about the potency issue a bit more, the amount of THC increasing over time, I mean, do you have a feeling for why that is? Is that a consumer choice? Is it that people just really like the effect of the high THC? Is it a tolerance issue? Where
they are? This is a very important question, and in some way, it's not a question that has been addressed directly by research, but now we have under indirect evidence of why this might be. So the control of the market, of course, at least in UK, and then Robin can comment what has been happening where it's been legalized, but in the UK is a black market. So you might wonder, what is the interest of a drug dealer is to get people coming back. And so now we do know, because of the work of Tom Freeman and before Valerie Curran, we know that higher is the concentration of THC in a type of cannabis, faster you become dependent. And of course, if you're dependent, you're more likely to keep going to your drug dealer. They compare the data on high potency type of cannabis with the one of type of cannabis that had less THC and more CBD cannabidiol. And what they found is that, if anything, the presence of cannabidiol is associated with a reduced chance of becoming dependent. And this is to a point that Tom Freeman is now developing his research in the direction of thinking of using CBD cannabidiol to treat dependence. So we do know that certainly you get much more, you get dependent much faster, and you're less likely to be able to stop your cannabis use. So you can imagine that this is an observation that has been very helpful for the black market. In terms of, do people like the effect more? Well, again, if you think about the analogy with alcohol, you can enjoy the effects of alcohol that you have a beer or that you have whiskey. But I guess stronger is the alcohol, faster is the effect. But when you ask the people I see in the clinic, they will tell you that, in fact, where initially they found the potent recreational effect pleasurable, then in the long run, they would also experience some of the harmful effects beyond the psychosis. So feeling slowed down, impaired concentration and attention. They would initially have a benefit on the sleep, and then they would have a reverse in the sleeping pattern. And they would say that necessarily the high potency wasn't the first choice. It was the only choice at that stage of their use.
So sometimes people, academics and clinicians, will say, but this is a good reason for legalizing cannabis, because the dealers are make more money by selling you potent cannabis. If it were legal, then we could insist that there was a whole range of different potencies available. And so if you go to Holland, or if you go again particularly to Colorado, which is the sort of wild west of cannabis use, you find that they do indeed sell lots of different types of cannabis, each with the amount of THC and CBD indicated. But what has happened, of course, is that people, instead of people saying, well, I'll just have the old-fashioned mild stuff, that people graduate to the more potent. So wherever in the US there's been legalization of cannabis, the potency has increased rather than decreased, disappointingly.
One question I had is, we know that obviously cannabis works by interacting with our endocannabinoid system, much like opiates interact with our system of endorphins. Do we have a clear understanding of what the function of the endocannabinoid system is independently of cannabis use?
This is a wonderful question, especially because I don't know you are both much younger than me, and I don't know how much teaching you had on the endocannabinoid system. So the endocannabinoid system was firstly described in 2008 by a Scottish pharmacologist, Roger Pagery. So when I went to medical school, and not been discovered yet, so there was no chance for me to have any education, but there is still very little education. And I've asked younger colleagues, they are currently medical students. So If we think about the general function of the endocannabinoid system, we are beginning to know more and more, and there are actually world now leading experts on the endocannabinoid system. There is an endocannabinoid research group that meets regularly as an international conference. And what is interesting about the endocannabinoid system is that, first of all, the receptors, the endocannabinoid receptors, are expressed in the brain in very early stages of development in uterus. So as soon as you begin to develop neurons, you will have glial cells, you will have the endocannabinoid receptor, which are in this specific case CB1, but also CB2. But as soon as we develop liver cells and lungs and immune cells, we have the expression of the endocannabinoid system. So evidence suggests that the endocannabinoid system begins to have a very crucial role in development of some of these very important organs, and certainly the central nervous system from early stages of the human development, and then throughout life. And we think as psychiatrists, or I'm obviously interested mostly on the central nervous system, but as I said, there's a crucial role in the immune system, and therefore the interaction between these different systems, but also the lung function, the liver function, and also the bone development. So when you think about it, you can think how many roles the endocannabinoid system has beyond psychosis and mental health, and perhaps how some of these other effects are also linked with what we see in psychiatry. Certainly, we know it has a very primary strong regulation of appetite and of sleep throughout the high abundant expression of the CB1 receptors in the hypothalamus. And we do know from our patients that one of the first effects that they experience is changes in appetite and in sleep. And what we now know, and actually temperature regulation as well. And what we now know is that for most of these effects, or at least the one on sleep, appetite, and temperature, you have a U-shape effect. So when you have low THC, you might find that you have very little effect on these three functions. When you increase it to a certain level, you have an improvement of sleep, an enhancement of appetite, and a sort of increase of temperature. But then if you go further high, you actually then have a reverse impact with hypothermia, reduced appetite, and impaired sleep. Which is why if you take an extremely potent type of cannabis, or if you take spice, which Robin might comment on, which is synthetic cannabinoids, they are 100 times more powerful in terms of their affinity to the CB1 receptor. You don't present with hot flashes, you present with severe hypothermia, which is not what you get when you have a little bit of cannabis, where you tend to feel hot. So we're now beginning to know about the physiology of the endocannabinoid system. And we're beginning to know, thanks also to lots of the work done by colleagues like Oliver House and Sagni Bhattacharya at the Institute of Psychiatry, but also other in the States, on what happens when THC and separately CBD enter the brain and they interact with CB1 receptor in specific parts of the brain when they are abundant. But I would say that we don't know as much as we know about other systems like the dopamine system or glutamate and GABA. But what we certainly know that is interesting in the context of psychosis is that when THC binds the CB1 receptor and also CB2, which are also expressed in the brain, it finds them mostly on GABA and glutamate neurons. And we know that GABA and glutamate neurons have a very important role in regulating other neurotransmitters such as dopamine, but also, for instance, serotonin and other monoamines. So what we can imagine is that if you disrupt a system that is supposed to regulate by GABA and glutamate downstream neurotransmitter, like for instance dopamine, you might have changes in function which are normally regulated by dopamine, or you have experiences which are related to dopamine, like the one of psychosis. And the difficulties is that if you give people even reasonably high doses of healthy volunteers, reasonably high doses of THC, and then you want to measure how much dopamine they release, you don't get a huge dopamine release like if you were doing this with an amphetamine challenge, because the interaction between THC and dopamine is mediated by other neurotransmitters changes. And so it's a much more sophisticated fine-tuning of the dopamine transmission, and we still have to understand this in great details.
And one of the problems, of course, is that we know what cannabis plants do because they produce a THC, and we know what THC does to a limited extent. But these synthetic cannabinoids, of which there are now more than 500 on the internet, they all have in common that they hit the CB1 receptor, but some of them do lots of other things as well. And it's just that some chemist in Israel or China, these are the two countries from which they tend to come, got a new compound that hit the CB1 receptor. He puts it on the internet and he markets it. He doesn't test it in animals. It's tested on the first humans that swallow it.
Yeah.
And of course, sometimes by accident, it knocks off it damages the kidney tubules, or it causes myocardial damage. And several people who've used this new synthetic cannabinoid die. And then that's withdrawn and they produce another drug. And so we go on.
And you've touched on this, how it might lead to psychosis in terms of whether it's a sort of more long-term effect on the dopamine system, some kind of dysregulation. I mean, is there a leading hypothesis at the moment about what might be happening? Is it anything to do with the acute effects leading to some, the psychotic-like effects that people can experience in the acute stages? And does that somehow set people up?
Well, this is a great question, because one of the things that we often get asked is, well, is there a difference in terms of your risk of developing psychosis if you are a current user, so you are actually currently using your cannabis and perhaps coming in and out of psychotic experiences when you are intoxicated, compared to somebody who has stopped, for instance, 3 years ago, was using very heavily, then they stop, and what is their risk now of developing psychosis? So I think you can look at it in two ways, and I'll give you the example of two of my patients to make it clearer. So there is the story of the gentleman I shared with you who acutely sort of bombarded his brain with THC and went psychotic very quickly. So in his case, of course, the impact was the one of an acute, very intense exposure, and that's gone much beyond intoxication because it's lasting 20 days. But then there is the example of many of the people I see in the clinic who have used very heavily for a long period of time, and then they stopped, and then something else happens in their life, and then they develop psychosis. And so you wonder if it was primarily a biological sort of route by which they perhaps had altered the ability of the dopamine system to reset in the context of another stressful or exposure to another risk factors. Or it's also the fact that if you had been running on paranoid perception of reality for a long time, because one of the things that cannabis does, and there are lots of experimental design of giving cannabis to healthy volunteers and measuring their propensity to develop paranoid ideas and become suspicious and interpret the environment in a sort of psychotic type way. If you have been doing that for a very long period of time, you might have changed also in terms of psychological schema, your propensity to interpret the environment. And so if something adverse happens to you, that might sort of further compounds your propensity to think that if your neighbor has become very noisy, it's not actually a coincidence, but it is part of a conspiracy to harm you. Or if you fail your exam, that's not that you've just failed your exam, but there's actually there is a plot against you achieving what you wanted. And so it's difficult to disentangle the way a mind has learned to process the environment from the underlying biology. And we don't have enough study, and we are actually analyzing some data that we have from an international collaboration that we might talk about, because we have data on people when they started, and from the time when they started to the time when we interview them, which is usually in the mid-20s, if they have at any point stopped and then restarted again, or people that have used all throughout, or people that only use it for a limited period of time, and compare this different trajectory of use with risk of developing psychosis. So how do you compare somebody who was using at the time or when they developed psychosis, so a more kind of current users, with people who used in the past and stopped, to see what is more relevant? Is it more relevant having altered your perception of the environment when your brain was still developing and you acquire that risk and you never lose it? Or is it to use close to the time where then you get over the threshold of a clinical disorder?
It's a curious thing about cannabis and THC that it's much easier to induce psychosis in a normal volunteer in a lab than it is with cocaine or amphetamine. If you were to volunteer to take amphetamines, then you would get excited and activated, and you maybe wouldn't sleep. But it would take several weeks of taking amphetamines before you would go psychotic. We know this from rather unethical studies carried out in American prisons back in the 1960s. But if we give THC intravenously to a normal volunteer, then in about 50% of people, they will get psychotic symptoms. They won't last long. They'll last for about 2 hours, and then they disappear. So it's odd that we know the neurochemistry of amphetamines and why they cause psychosis, because the impact on dopamine, but it takes a while before they go psychotic. Whereas with cannabis in the lab, you can actually induce the
within
psychosis.
half an hour.
Yes, I remember particularly one lady who my colleague Amir England gave the THC to, and then we asked. She was continually asked how she felt, and she said she felt absolutely fine. There was nothing at all. She must have had the placebo and not the THC, but she looked terrible. She looked very odd, and her eyes were darting around the room. We said, "How are you? All right? You sure you're okay?" And she said, "No, I've had no adverse experiences whatsoever, no hallucinations or strange ideas." And so we thought that was a bit odd, but she went off home. I actually, once the effects had all, of course, had totally worn off. But the next day she sent us an email saying, "I'm very sorry if I've ruined your experiment. I was so psychotic and so suspicious of you that I thought you might be out to do me harm, and therefore I shouldn't speak to you at all and tell you anything about the experiences I was having," which is actually a little reminiscent of what happens sometimes with patients who are paranoid. Sometimes patients can be very paranoid, and then they stop being paranoid, and you think, have they got better? Or are they now so paranoid that they're even suspicious of me? And that was the case with her. So is it having lots of little, I think, as you were implying, is it the psychological effect and building up the fact that you begin to become suspicious of your friends? That these are just intermittent effects, but if you keep taking the cannabis and then stopping the cannabis, does this build up so that your cognitive schema changes, or is it simply a neurochemical thing? We don't know the answer to that.
And I guess, if I may, one again analogy, because I think what is helpful sometimes is not to have this tough idea that cannabis and psychosis is unique. Nothing else is like cannabis and psychosis. And sometimes if you stop and look what's happening in other fields, you can learn very, very interesting stories that can actually tell you that perhaps what's happening in cannabis and psychosis is happening elsewhere. And if you think about alcohol and liver disease, you have people that can drink one night and end in accident and emergency with alcohol hepatitis. And that there are people who get to liver damage at a different pace. And I feel very strong about this because I have the genetic mutation that gives me the alcohol dehydrogenase variant that makes my metabolism of alcohol very toxic. So I get lots of the acetaldehyde, which is responsible for the unpleasant effect. So when I drink alcohol, I don't necessarily get cheery, pleasant and sociable. I get sort of moany and sick and headachy and red. And
terrible.
And so, and I know in my experience also of alcohol that I get to the unpleasant effect so quickly that I'm never going to probably become an alcoholic. And if I did drink for some funny reason, as I did once as a trainee psychiatrist, going out with my colleagues too much, I get very sick. And I don't need to.
I don't think they want to know
the
intricacies of
no,
this.
No, but this is just an example to say that sometimes to also stop and think, to personal experience is a more general other example of, not even in psychiatry, interaction between using a substance and the damage you can experience can be very useful to look then into your area.
And perhaps to change tack slightly, because obviously what another problem that we know happens with cannabis is addiction, but hence a reason I think why people can get to problems of addiction, and I guess also the issues with daily use of cannabis leading to psychosis is because they enjoy it. So I wonder what you can tell us maybe from your clinical experience about some of the reasons why people like using cannabis.
So yesterday I did a little interview for actually the Maudsley Learning with one of the young men who has been coming now to the cannabis clinic for 1.5 years, and in fact has stopped using cannabis 10 months ago. So he's doing very well. And one of the questions I asked him is that, why did you use cannabis? Why did you start using cannabis, and why did you continue? And he lit up and he said, wow, because I loved the effect and I was smiling a lot, and I've not been smiling since. And there is this ambivalence, because then you ask him, but how, has your life changed since you stopped? And he said, yes, my life is wonderful now. I read, I spend time with my friends, I can do all the things I stopped doing. I'm not psychotic anymore. But still, he has this amazing memory, which you can see in his facial expression, of the pleasurable effects that he had when he started using. And so the recreational component, which people describe as a sort of euphoric state, and some of them might say to you, where you have this sense of understanding reality better, of feeling music, not just listening to music, or being extremely chilled out, so very little bothers you. And it's quite interesting if you think that one of the initial experiences to be chilled out and detached from anything around you. And the flip of this is that they become very paranoid. So the environment becomes extremely hostile, even when actually it's totally neutral. And this is a sort of why it becomes for some of them difficult to make the decision, or even to consider the possibility that the difficulties they are having with the mental health is to do with cannabis, because what the initial experience is what remains with them, which is of something that made them chilled, less stressed, full of ideas, and more creative. And that's what they keep seeking, which again, if we think about alcohol, when people keep drinking, apart from treating their withdrawal symptoms, they seek that initial pleasurable effect that they remember was at the start of their use.
And sometimes people, well, they will still get the pleasurable effect, but they know that in a little while later they'll get the paranoia. So you can get initially a chilled out and decrease in worries and a bit of euphoria, and at the same time begin to feel paranoid. And when you ask people, if you know it makes you paranoid, why do you still take it? He said, but I still like it. I still enjoy it. But some people, that becomes less and less as time goes by, and the paranoia becomes more and more. I guess it's a bit like alcohol. There are some people you meet when they had their first drink at 13 or 14, they said that this had a magic effect. And other people said, well, my first alcohol I ever had was Guinness, which was horrible. So it may be that some people are pharmacologically different, and they may have a different response to alcohol or a different response to THC.
I wonder if that might link us into your work at the Cannabis Clinic. Is that enjoyment and finding a way to work with people to reduce their cannabis use part of what you do there?
Oh, it's definitely my enjoyment. I absolutely love the work at the Cannabis Clinic. And I have to say, it's one of these experiences as a clinician where I started off because I thought that with my colleague, we could offer a useful service. But in turns, I've learned so much that if on balance, probably we have to consider what we had offered and what we had gained. If not equal, we probably have to date gained more, because I have learned an extraordinary amount of very helpful information, which also have informed my research, from spending lots of time just dedicated to talking to my patients about their cannabis use, rather than the quick few questions that you ask in the context of the long psychiatric history that as clinician we take when we meet people.
One thing that has amazed me at the clinic, in our research, we have always said, how often do you take cannabis, and we differentiate that people into those who'd never taken cannabis, those who occasionally take it, those who take it every week, and those who take it every day. But we didn't think to ask how many times do you take it every day. And at the cannabis clinic, it's people who are taking 5 times a day, 15. I did not believe that people could smoke,
I'll give
20 joints in a day.
I'll give you another anecdote. So the cannabis clinic started because we got funding from the Maudsley charity. And at the beginning, there was me as a consultant psychiatrist, and then we had a wonderful nurse, who was a band 6 nurse who had some interest in actually tobacco and cannabis, and she's doing a PhD in people who are using tobacco and cannabis and want to stop. So she was a perfect person in her role. And then I had the usual sort of colleagues who come and do an attachment with us, who wanted to know a bit more, who were offering their time. And in fact, they were all clinicians. And the reason I'm bringing this up is because the way we work is that any of the care coordinators, so any of the nurses or people who care for somebody with psychosis in early intervention in our trust, can send me a very simple email and say, I have a patient working with me, and he or she is also using cannabis, and they are motivated in making some change about their cannabis use. So this is all I need to know. I don't want to know they're motivated to stop. All I want to know is that they are prepared to consider changes and have some motivation for it. It doesn't have to be full motivation. So usually when I get this referral, the first step is that we meet with the person and we collect detailed information about the cannabis use, but also about their sleep, their general physical history, their anxiety, their depression, some of the main psychotic experiences, their cognitive function, and we use that instrument that in psychiatry we use normally, so it's not a research instrument. And also we have some measures of if they are dependent. And the reason we have chosen some of these interviews is because you get a score. And this is useful for the person. They actually want to know how they score in terms of their cannabis use, and they can monitor this over time. But the reason I'm bringing this up is because being the only consultant psychiatrist, sometimes I might be on leave or I might not be well. And so twice, Robin covered for me and came in down to Kennington Lane to do this that we call the core assessment. And it was useless because he got so interested in what the patients were talking about cannabis, that the core assessment, rather than lasting an hour, it lasted 2.5 hours. And of course, we need to have a certain degree of time management. But this is to say that we don't often have time in our routine to talk to them about their cannabis use. And what I've learned is that cannabis plays a huge role in their life, not just about good and bad effects. There's much more about it. It has implication on their network of friends, on their relationship with their family, on the cultural background, on how much money they spend, on what they get to do in terms of education and unemployment, and achieving or not their aspiration, on getting in and out of relationship. So then once they might get a girlfriend or a boyfriend who's smoking with them and everything goes well, and then they break up and they get one that doesn't want to do about cannabis, and they find themselves having to make choices. So it's a very complex interaction between their cannabis use and their life and the choice they might make to reduce or stop. And what we decided to offer in the cannabis clinic was something very simple, because I'm not an addiction specialist. So I was able to collaborate with the main addiction specialists between King's and Lam, who are all parts of, if you like, the steering committee of the cannabis clinic, and get ideas from them on what has worked in addiction. And so very simple thing, in addiction, there's been the use of vouchers to reward people adhering to their goal and attending the sessions. And so we use the vouchers. In addiction, a classic approach is harm reduction. So you don't just ask people to stop, but you ask them to set their own goals on where they want to start, either reducing, changing the type of cannabis, changing the time of the day where they use, and then bringing in things that I know they work in psychosis, especially in early intervention, vocational approaches. Okay, what do you want to do with your time? You're going to save some time from using cannabis. How do we fill the time with things that are meaningful to you? And then we have linked with other activities that are available in our catchment areas, like groups. Unfortunately, some of these things during the pandemic stopped, but things like groups where you can go and learn about music, where you can go and play football, or give them the opportunity to enroll in colleges courses, and so on and so forth. And what has been great is that the Cannabis Clinic has been working on resources which are not conventional resources, because has been running on collaboration with experts, but with thanks to the voluntary work of clinical placement MSc students from King's, who with me have agreed to take on the challenge of having weekly session with the patients and starting the journey with them, starting with getting to know them and what they are with the cannabis use, setting goals with them, creating graphs that record the trajectory of the changes and mark milestone in this trajectory, that agree with them what type of vouchers they want, because patients choose their own vouchers. So I set the amount, obviously, because we don't have huge resources, but they decide if they want Amazon rather than Apple, rather than Ocado, rather than whatever it is that they enjoy. And this, of course, motivates. So some of them, because of the voucher, have bought a laptop and they've started using it for their education. One of them has bought himself 30 books and has gone from not reading at all for 5 years to reading all of the Harry Potter and I can't remember the other series. Some have done shopping to be able to cook for their family. So it's been amazing to see how they've regained their time from the cannabis and how they have been using the resources that we make available to them. And the other amazing experience of the Cannabis Clinic has been the peer group. So peer support in addiction is a gold standard. You know, the AA, all the anonymous society, now you have an AA for marijuana, you have it for cocaine, for all the substances. But there wasn't something that was bringing together the experience of being psychotic and cannabis dependent. And so whenever in the past I had referred my patient with psychosis to general addiction service for cannabis use, they were not fitting in, because yes, they were bringing the experience of being dependent on cannabis, but they could not relate on the psychosis, which of course was a huge component of their experience. And so we thought to set up a peer group for patients with psychosis and cannabis use under the umbrella of the Cannabis Clinic. And initially we were doing it in person. We were renting a room at Clapham Library and we were doing it every 2 weeks. Then the pandemic came along and we said, oh gosh, we had to stop it. And then I thought, well, the AA is going online. The Cocaine Anonymous is going online. Why can't we do this? And so we decided to go on Zoom. And we started running it weekly because, of course, it was much easier to do it. And what we could do was we could involve patients who are on the ward, which is a great time to start thinking about making a change because you are forced to stop your cannabis consumption anyway. And so with the help of extraordinary nursing staff like Alison Peachy, who is a dual diagnosis practitioner for the inpatient in Lambert, and other colleagues throughout the trust, now on Tuesday evening, we meet between 4 and 5 on Zoom. And we have patients who connect from the ward and patients that connect from their own community accommodation using the laptop or the smartphone. And we start with 10 minutes talk from experts in the field. So we had people that came from Canada, or a lady that connected with from Colorado. We had people from Yale. We have our local experts. And we have a 10 minutes on facts and knowledge. And then we had the rest on discussion with them. And then we have times when we just invite guests who are people with lived experience of both, who have stopped many years ago and transformed their life. We have a time when we catch up on how they're getting on with their individual goals. And so we remind everybody, for instance, that such and such has been off for 51 days.
Everybody claps.
And everybody gets very excited. And that's the other, I just stopped for 2 weeks and everybody gets very supportive and said, wow, 2 weeks is a great achievement. Don't give up. We bring in our colleagues from the smoking cessation service in Slum who have given talks about what if you're using the two together? Are you sure that is no harder for you to stop cannabis because you have tobacco in your joint? And they're wonderful because they actually join every peer group, and so they're able to contribute if there is a discussion about tobacco. And we have invited some of our KCL and Slum experts on addiction who have talked about techniques that maybe they are used for cravings, which are useful for any cravings, either that you crave for cocaine or you crave for cannabis. There are things like the famous 5Ds, who, not being an addiction expert, I had no idea existed, who they all found it very, very helpful, that you can use to, I don't know if I can remember all of them, but one is you get craving, you distract yourself, you find somebody to discuss things with. You have a drink, clearly a drink of water or a soft drink, and I can't remember the others. This tells you how useless I am, but they all know them very well. And when they come up, they will be able to tell you what the 5 Ds are. We have learned about boredom and all different things you can do. And this because we invited people that do addiction work. And then we had Robin coming to talk about the link between cannabis and psychosis and what do we know about it? What is the underlying biology? And one of the main lessons I've learned is not to be patronizing with people just because they have mental health problem or because they are actually unwell, or even they've been using cannabis up to half an hour before you do the peer group. Because whenever we have shown them data, we have shown them graph, we have shown them complicated piece of information, there's never been a time where we haven't had a clever question, a sensible question, a challenging question, demonstrating that if you give people knowledge, they can get the best out of it. And when they don't understand, they ask you to be clearer, but they don't want to be treated as you should feed them the simple story. They want to know the whole story and then get the best out of it.
So some of the people who have been coming to the clinic or to these virtual clinic meetings for a year, they're much more knowledgeable than the average psychiatrist.
Yes.
Because they've heard the world experts on addiction or the world experts on psychosis or experts on legalization or on neurochemistry, on the endocannabinoid system. So these, by and large, are mostly working class people from South London who
have not completed forget about the A levels. Some of them, most of them, 2/3 of the one we have right now, they haven't even completed their GCSEs.
But of course, the thing is that one of the reasons they haven't completed their education is because, of course, the cannabis. So underneath, they're once they're off the cannabis, they get back to proper intellectual function and can begin to rebuild their lives.
Yesterday, I was very pleased because we had a peer group on legalization, which of course is a very important topic for them. And at some point, I don't remember what Robin said, which was a sort of provocative question. And one of the peers said, well, I think what is really important, I dismissed the issue of legalize yes or no. He said, what is important is to give people knowledge. And I thought, yes, this is what I say when I get interviewed by the BBC. And I said, next time I'm going to send him, because this is exactly the point, to give people information to make the choices. And for them, in fact, what came out yesterday is not the legal status of cannabis, is really to understand what is behind it and what might be the effect, and having control of the life. So the experience of the cannabis clinic has been great. And I now have 4 MSc students who are analyzing the data from the first 17 patients who have completed the treatment to look at the changes in the cannabis use. 10 of them are completely stopped and 7 had a significant reduction. And other measures like cognition, level of functioning, psychotic symptoms. And it's very interesting to see this data to also take a quantitative form apart from my personal, I'm very passionate about the cannabis clinic, so I find it very difficult to be balanced.
So this clinic has become quite well known, and for example in the media people talk to us about it. The chairman of our trust, Sir Norman Lamb, he wanted to come and be taken round the clinic by Marta. But there's nothing there. It's just rooms begged and borrowed. And similarly,
there are not even rooms.
Yes, then that's true, and there's no funding. So it's run on a wing and a prayer, and the efforts of volunteers, Marta and MSc students. So far, SLAM haven't been able to put any money in it. So that's one of the big risks, is that when the charitable money runs out, and Marta's funded by the MRC, when that runs out, the whole thing might collapse. But it's difficult to introduce new things to the health service, because if it's a new drug, then the drug companies probably spent $1 billion showing its efficacy. But if you're introducing a new innovation that nobody else much has done, then the NHS says, well, what is the evidence?
What is the money saving?
Yes,
probably
take us 5 years to run a proper trial to show the effectiveness of this.
But one thing that the cannabis clinic has done has won over the interest and the support of. In fact, I will use a sentence that, not being English first language, I wouldn't have used because I wasn't really sure what the meaning was. but now I know, that has been used by the dual diagnosis nursing staff lead. It was a lady called Irene Moore, and Irene is a nurse herself. And she said the cannabis clinic has won the support of people from bottom up. So what she's saying is that the cannabis clinic has the support of the patients, of the nursing staff on the ward, of the staff that works with the patients, then of some of the medics who had the experience of referring the patients.
Lots of those consultants.
Yes, but we haven't reached the top.
No, people that are holding the money.
No, but we
got to them.
And if you ask me as a clinician, apart from the fact that money is what is needed to keep it going, and especially to be independent of me, something that is set up and can run, that I'm on holiday or I'm not on holiday, that I can continue to do this or not, for me is a validation in itself that is actually the people who are receiving the service and the people who are collaborating with that think we're doing something helpful. And the data are coming, and you just have to be a bit patient and be able to put a bit enough to convince that there might be some money saving, there might be less admission to hospital, which is a big saving,
For
obviously.
Sure there is.
But we need, I need longer, because these are the people I'm looking after right now with the clinic. They've been off for 1.5 years, they've been off for 51 days, they've been off for 2 months. So to show money savings, I need to show that at least in another year time, there'd be no admission to hospital compared to the year before, for instance, which is something we're planning to do.
But what a thing to say in psychiatry, especially in terms of engagement, and actually to have a service that patients and people do want to use and they do find helpful is amazing. If that's a way that we can actually get people on board with working with their mental health team, with finding that they get some kind of benefit from them. I mean, as a young clinician, that's the kind of thing that makes you want to keep going to work.
Yeah, no, and for me to put on at 4:00 on a Tuesday Zoom and have 34 people logging in, and we had people who have been with us for over a year every Tuesday afternoon, or some who send me apologies to say, sorry, I can't make it today because I have a college course. When sometimes I'm sitting in my clinic, you would have experienced this, especially first episode psychosis clinic, not turning up is actually quite high in general. And again, this is not because we're doing something exceptional, but I think the fact that we are bringing them a sense of sharing their experience and being empowered by knowledge rather than telling them what to do, which is sometimes what you can in the clinic. Sometimes we don't have time and resources to do anything else than telling people what they should do. Take the medication that we recommend and not do the things that causes them harm. But this is a model that certainly, even in my own clinic, has changed my approach when I come to a discussion around cannabis.
Of course, also it's interesting to do this while people are in their own homes. And one unusual experience that we've had is of one of our attendees lighting up a joint in the middle of the discussion. And we, of course, weren't quite sure what to do about this, but the other patients scolded them and told them to behave properly, not be disrespectful to light a joint in them. And then he wouldn't be able to remember anything. And
he never did it since.
Actually, he's become a great advocate of the
No,
clinic
now
since.
he's a great advocate, which surprises me, because if anything, is somebody who started off saying, I'm coming along to hear what you say, but I think cannabis is wonderful and I will never consider doing without it. And nobody has told him he should have done without it. He made up his own mind, feeling free to be himself, even on the day when, in the presence of one of the world leading experts connecting from Yale, lit up, and he told him. But again, the other actually thing for me has been moving. By definition, I tend to invite speakers who are also clinicians, because some of the people that come to the peer group might not be very well, and I just want to make sure that the people who are giving the talk are able to understand and are able also to respond warmly and caringly and respectfully enough if a comment comes out of somebody who is acutely paranoid. And so far, we had psychiatrists and academics from the Netherlands, from different places in the United States, from Canada, from the several parts of UK, and they've all been amazing. And they all had such an extraordinary interaction with the peers, which tells me that psychiatrists can be wonderful. And I remember once we had an interaction with one of them who said, oh, well, my experience of psychiatrists here and there. And then I said, hold on, I'm a psychiatrist. Really? He said, and I said, and your speaker is a psychiatrist. And I said, so you can see psychiatrists can be very nice people. And he stopped and thought about it. And he said, yes, I shouldn't generalize. And that was nice, because I think psychiatrists are wonderful clinicians, as they are wonderful cardiologists. But sometimes, because of the type of interaction we have with our patients, we leave this perception that we are not necessarily always as caring, as respectful as we could be. And so I think, as I've learned from them, they've also learned that psychiatrists can be all of these things.
I think also when you're seeing people virtually and talking to them, you're not seeing them in our clinic with our nurses at our desk, and they're on much more equal terms. And of course, they can switch off whenever they like. So, but I think that's not just down to the clinic, but that's talking with patients generally. I think you
have more control of the environment.
To end up talking to them more as you would talk with friends, rather than you are the doctor, or in my case, the professor, and they're a humble patient. So I think it helps you to learn from our experience with virtual interviews. They're far from perfect, but you're on a more equal footing, I think.
I wonder whether, to finish, if I could ask you if there are any misconceptions about cannabis that either patients or clinicians have shared with you that you would hope that a listener to this podcast can take away.
So some recent studies have suggested that the people who come to harm and specifically develop psychosis when they use cannabis do that because they are loaded with genes for psychosis. So it's their genetic predisposition to psychosis that, first of all, puts them in a position of using cannabis and then of developing psychosis. And therefore, the link between cannabis and psychosis is really just explained by the fact that these people have lots of schizophrenia genes. Now, there are some studies that have suggested that the genes for schizophrenia influence cannabis use, and therefore that influence the association between the two. But there are also studies that have shown the opposite. And the reality is that most of the genetic research has looked at the usual question, have you tried cannabis, yes or no? So it's really looking at how schizophrenia gene might increase your chance of using cannabis at some point in your lifetime. One of the things that we are trying to do is to see, is there anything specific in the genetic of, we talked about the endocannabinoid system, the dopamine system, the GABA system, all those systems that we talked about have a biological relevance in the effect of cannabis on the brain that perhaps can explain why some people, even when they use whatever the cannabis that they use, are much more likely to develop psychosis, because not all skunk users develop psychosis. So it's not enough to use high potency and to use high potency every day to become psychotic. So there must be something else. And Robin mentioned it might be the way you metabolize the cannabis, but it also might be how genetically vulnerable to cannabis your dopamine or endocannabinoid system or whatever it is. So we are looking at that. But one thing that in our research we certainly have not shown is that the people that use cannabis are people with more schizophrenia genes than you and I. So it's not all explained by schizophrenia genetic predisposition, the link between cannabis use and psychosis. And the reason why this is important is because what you don't want is just to give a message that is only people who have a family history of psychosis that shouldn't use cannabis. Because certainly this is a group that shouldn't use cannabis, because if you have a familiarity for psychosis and you add another risk factors that can be childhood adversity, cannabis use, obstetric complication, you're not in a good place. But there are also lots of other people out there who don't have a family history of psychosis, who might come to harm. And so I think what I would like to see is people being more aware of what to look for when they use cannabis. We all know how somebody drunk looks like. We all know when a friend shouldn't get in a car and drive after we've been out for a drink. But I think for people, it's very difficult to know when somebody who's using cannabis is beginning to transition towards established psychotic experiences. As Robin said, somebody who's very paranoid might, because of that, tells you that he's absolutely fine. And so how do we as family members, as friends, or even as individuals can begin to understand that cannabis, in our case, is beginning to cause us harmful effects? And so I guess to answer your questions, I would like to challenge the misconception that everything is explained by genetic predisposition for psychosis. And two, how can we use our tools that as clinicians we have in understanding and explaining psychosis to help people who don't know about psychosis how to recognize it when it begins to creep in their life or the one of the loved ones.
I think the other area is the significance of cannabis-related psychosis. Undoubtedly, psychiatrists have changed their mind over the last 20 years. I used to get invited to debates to debate, does cannabis cause psychosis? Yes or no, and I would debate with some other person, and I nearly always lost because psychiatrists didn't think cannabis caused psychosis. I never get invited to such debates any longer because it's not a question. It's widely accepted that cannabis can cause psychosis, but it's not widely known how big a deal this is. And we know from studies that Marta has played a big role in that psychosis is 5 or more times commoner in South London than it is in southern Spain or southern Italy. And one of the big factors in this is that we use much more cannabis and much more potent cannabis in South London than they do in these areas. But the other thing is that psychosis has become much commoner in South London. And one of the reasons why poor young doctors like yourself are so busy is that there's far more people with psychosis than there ought to be. That there's 2 or 3 or more times more psychosis than there was when I was a young clinician. And of course, sadly, the budget for the mental health services has not gone up with this. So one of the reasons why the mental health services are, I was going to say in such a mess, well, in some parts of London they are in a mess, is that we're overwhelmed by far more patients than we really expect to get.
Do you want to finish maybe commenting on your new data that actually we mentioned at the very beginning on cannabis rates and psychosis rates?
Well, we know that generally, that as cannabis becomes more acceptable, and many people think cannabis is medicinal, and one thing we haven't touched upon is the industry, that just as the cigarette industry, the tobacco industry, denied the existence of any side effects or adverse effects of tobacco, now the cannabis industry, which is big in North America, and of course is now being bought over by Philip Morris and Budweiser and all these big companies, and they are denying that cannabis has any adverse effects. In fact, it is medicinal and it's good for almost every illness under the sun. So cannabis consumption in the UK declined between 1996 and 2013. Then it stabilized and now it's going up. And that, I think, is the influence of wafting over from the USA that cannabis is good for you. And it's safe. It's hardly a drug at all. It's a sacred herb. It's a leaf. But now we know that the country would save a lot of money if we could abolish a skunk and go back to old-fashioned 1960s marijuana, then we would save a lot of money. But sadly, I don't think this is going to happen. But what we can do is develop public education campaigns so that people know, just as people know that a bottle of vodka a day is not good for you, that say 5 joints of skunk a day is not good for you. People don't know that.
And this is something that your data is showing, that as the potency of cannabis has gone up or as it's become more widely used, that we've seen the psychosis rates increase in London or in the UK.
Yes. I mean, that's not the only reason, but I think, and of course, people take other drugs. But I think if we were to go back to the use of cannabis as it was 20 or 30 years ago, the psychiatric services would be able to deal with a much smaller number of patients.
And actually, I very rarely correct Robin, but I would like to correct one thing. Robin said that when he commented on the link between the number of new cases you might expect when there is lots of, for instance, high potency cannabis use. It might also relate to other drugs or other things. Indeed, but in the study that we did, when we look at this, the proportion of new cases of psychosis you might expect to be linked to skunk in London by high potency cannabis in Europe, we did actually control for the potential contribution of other drugs, especially stimulants like cocaine, methamphetamine and amphetamine, who we know increase the risk of psychosis. And we also control for lots of the environmental and socio-demographic risk factors that play a role. So despite we control for that, we control for age and gender that we know have an effect on rates of psychosis, we did still find a significant contribution of cannabis, which doesn't mean it was the only contribution, but certainly was one that could have prevented up to 30% of new cases in Southeast London and up to 50% in places like Amsterdam. So an important contribution.
And the harm reduction message there is use less, use something like hash instead of skunk.
You can find it, but certainly use less. If you only find high potency, use less. And if you can have variety, use a less potent type.
Thank you so much. I could have carried on quizzing you and picking your brains for much, much longer, but I'm so grateful.
Well, we like talking about cannabis, as you can hear. It's much more fun. As a Scottish person, you get involved in all sorts of boring discussions about which single malt is the best. But the varieties of cannabis, I think, are much more interesting.
You are listening to the Thinking Mind podcast.
If you enjoyed today's podcast, we'd love it if you share it with a friend, or you could give us a rating on Apple Podcasts, Spotify, or wherever you listen. If you fancy it, you can even buy us a coffee to support the team, and the links for that will be in the show notes. Thanks for listening.